Good morning, everybody. Is it audible?
Yeah, it's audible.
Good morning, everybody. Welcome to the another edition of online anesthesia program. Nowadays, we are focusing on first year's curriculum. So, as a part of it, today morning we have two pharmacology topics. One is pharmacology of induction agents, that will be taken by Dr. Anaesthesia from Madhumil College, and Dr. Shivkumar sir will take pharmacology of muscle relaxants from Shimoga. And today's session coordinator will be Dr. Sarvabhadrani. I welcome all of you to this bright morning. Have a good time. Over to Sarvabhadrani.
Good morning, everyone. This is another topic of interest for the postgraduates mainly. Today's topic, the first topic is going to be by Dr. Anaesthesia, who is an assistant professor in Madurai Medical College. She has completed a post-graduation in Tirunelveli Medical College, and her topic for today is pharmacology of induction agents. Her areas of interest are cardiac anesthesia and ultrasound-guided anesthesia technique. Over to you, Dr. Anaesthesia.
Good morning, one and all here. I think I am audible. First of all, I would like to thank Dr. Edward Johnson sir and Dr. Shivaprasad sir for giving me this opportunity. So I'm here to discuss on the topic pharmacology of induction agents. Okay, what do we mean by induction? In general, to induce means...
Slide. Can you please share your slides, Dr. Anaesthesia? Your slides are...
Okay, ma'am, okay. Is it shared?
Yeah. We can see it now.
In general, to induce means to activate, but whereas in anesthesiology, it means to deactivate. With this note, let me get on into my topic. So my topic is pharmacology of induction agents. Why do we need induction agents? These are the takeoff agents. For a smooth plane of anesthesia, we need certain takeoff agents, and these are the our induction agents or the heroes here. So four main heroes in induction are thiopentone, propofol, ketamine, and etomidate. Though they all look similar, they do have individual properties and uniqueness. So induction agents broadly classified into intravenous and inhalational induction agents. But today we are mainly going to concentrate on intravenous agents. First of all, intravenous agents are broadly classified on the basis of their pharmacological structures into barbiturates, then substituted phenols, phencyclidine derivatives, imidazoles, opioids, and benzodiazepines. Opioids and benzodiazepines mainly find their way only in the co-induction and preemptive analgesia. They are rarely used in induction. So, coming to barbiturates, they are classified furtherly into thiobarbiturates and oxybarbiturates. These are based on the sulfur atom at the carbon quotient, which we will see later. Thiopentone and thioamylol are examples of thiobarbiturates, and methoxetal oxybarbiturate. Then propofol is an isopropyl phenol. Now, thiopentone, as you all know, it is a lyophilized amorphous powder. I think you can take a screenshot of this image so that you can evaluate after the session yourself, self-evaluate yourself. If you can reassemble these jumbled words. Okay, regarding the history. In 1930, Ernest H. Wohlweiler and Donally L. Tabben in Abbott laboratory synthesized thiopentone, but it was made into humans by only Ralph Waters and John Lundy. This is the picture of them. And the most important historical event, Pearl Harbor, finds the use of thiopentone in the war victims as an euthanasia agent. So coming to the structure, this is the structure of the barbiturate. So 5-ethyl, 5-1-methyl-butyl, 2-thiobarbituric acid. How is it named? See 5-ethyl and 5-1-methyl-ethyl, and the sulfur atom is present at the second position. If it is replaced by the oxygen atom, it becomes an oxybarbiturate. So this second sulfur atom is responsible for the lipophilicity and the potency of the drug. In this aryl and alkyl group, This is responsible for the hypnotic and the sedative effect. If it is replaced by a phenyl moiety, say in phenobarbital, then it becomes an anticonvulsant, a drug of choice in anticonvulsant. In this first position, if it is replaced by methyl or ethyl group, then it becomes oxybarbiturate methohexitol, which is used in ECT because of their lowering seizure threshold and prolonging seizure episodes. That is, they induce excitatory movements and involuntary movements, tremors. Now coming to the properties. It is a pale yellow powder. Hygroscopic means it attracts water. So it is always stored in the atmosphere, inert atmosphere of nitrogen, and with a 6% sodium carbonate to prevent the acid precipitate crystal formation. They are highly alkaline. Even the 2.5% solution itself has a pH of 10.5. So it is always, we have to use it intravenously carefully. So 2.5% solution should be used. It is bacteriostatic and it is also stable for 48 hours at room temperature in powder form and up to 1 week for as refrigerated solution. So coming to the mechanism of action, they act through GABA receptors. Gamma aminobutyric acid receptors. They are mainly of 3 types, A, B, and C receptors. A and C receptors are mainly ligand-gated ion channels, whereas B receptor is G protein coupled receptor. Barbiturates finds its place only in the GABA A receptor. At low concentration, they act as GABA facilitatory, and at high concentration, GABA mimetic. So, what is GABA? GABA as such, you know, it is an inhibitory neurotransmitter. So, this is the structure of the GABA receptor. It has a 5 glycoprotein units, 2 alpha units, 2 beta units, and 1 gamma unit. The central area is formed by the chloride pole, chloride channel, where the chloride conductance takes place. When GABA gets attached to these receptors or these subunits, the chloride channel opens and the hyperpolarization of the membranes, neuronal membranes takes place. Action potential threshold is reduced and neurotransmission is inhibited. This is the main mechanism of action of GABA. When they these benzodiazepines, barbiturates, and even etomidate and propofol, they are allosteric modulators of GABA. So, if any of these drugs finds its place in the GABA receptor, then the chloride channel opens, then hyperpolarization occurs, and the neurotransmission is inhibited. GABA receptors are mainly concentrated on the thalamocortical and the limbic system. And the other receptors are adenosine receptors, neuronal nicotinic acetylcholine receptors, and AMPA glutamate receptors. Now, mechanism of action. Barbiturates, when they get attached to the GABA receptor, at low doses, they are GABA facilitating. That is, they reduce the dissociation of GABA. But at high doses, they act as GABA even. This dissociation rate, reduced dissociation rates increases the opening of the chloride channel time. And hence, chloride conductance increases, hyperpolarization occurs, and then neurotransmission is inhibited. In high doses, they open chloride channel and increases the chloride conduction. So here it is clearly seen. GABA side, this is the barbiturate side, and the other benzodiazepine side is presented. When these finds its place, chloride channel opens and the chloride influx takes place. So pharmacokinetics, the 4 main aspects of pharmacokinetics is absorption, distribution, metabolism, and excretion. So before going into pharmacokinetics, we need to know what is zero order kinetics and what is first order kinetics. With zero order kinetics, the drug is eliminated at a constant rate. Whereas in a first order kinetics, it is eliminated at a rate proportional to the plasma concentration. So, barbiturates at usual doses follows first order kinetics. That is, they excrete fractionally. Whereas in high doses, they follow zero order kinetics. That is, they get accumulated and delayed recovery can occur. So here is the picture. Within minutes, when it is intravenously injected, when thiopentone is intravenously injected, within minute, that is not even a minute, with less than a minute, it reaches the peak in the blood. Then it is rapidly distributed to the brain and the highly perfused organs like liver, kidneys, lungs. Then it gets redistributed. Then it is distributed to lowly perfused organs like lean tissues and muscles. This takes place within 5 to 15 minutes. But later, it gets deposited in the fat, then redistributed after 2 to 3 hours, then gets eliminated, they are metabolized and eliminated. This is called the redistribution phenomenon. Usually, onset occurs within 10 to 20 seconds and the peak reaches by 30 to 40 seconds. That is its effect on the brain. Then duration, 5 to 15 minutes, but redistribution can occur, which may last even for 4 hours. The elimination half-life is up to 11.6 hours. So that is 12 hours. The volume of distribution is 2.5 liters per kg, approximately 125 liters, which is increased in females and pregnancy. It has two half-lives, rapid distribution half-life and the slow distribution half-life. Rapid distribution half-life is 8.5 minutes and slow distribution half-life is more than an hour. So, what all decides distribution? It is lipid solubility, ionization, and and the protein binding. So, when a drug is protein bound, it is not available in the solution. So, the metabolism will be slow. So, lipid soluble drugs are easy to cross the blood-brain barrier, as most of our cells are made up of lipid membrane. Then low ionization, that is, ionization is inversely proportional to the absorption. A low degree, when there is when the degree of ionization is low, it gets easily absorbed. So here is the 3-compartment model of a drug. When a bolus of a drug is injected, first it reaches the central compartment, that is the blood plasma area. Then it reaches the rapid effect site, that is brain. Then it gets equilibrated with the peripheral tissues, that is muscles. Then slowly it is equilibrating with the compartment fat and then gets redistributed in the plasma, metabolized and eliminated. Now, main metabolism is by hepatic route by microsomal enzymes. So the inactive metabolites are hydroxythiopental and carboxylic acid derivatives. Since thiopental itself is a condensation of urea and malonic acid, they get metabolized to inactive hydroxythiopental and carboxylic acid derivatives. It is water soluble, mainly excreted through urine. Then oxidation of aryl and alkyl phenyl moiety occurs at the C5 position. N-dealkylation occurs and desulfuration at the C2 is responsible for the long CNS activity. That is seen with the pentaforbital. So finally, the barbiturate acid ring gets destroyed. Now, excretion is mainly through kidneys, renal mechanism, and the lipophilicity is responsible for the increased absorption. And protein binding causes, high protein binding causes the decreased filtration. Elimination half-life is more than 11 hours. So, what the drug does to the body? Let's see. In central nervous system, it causes a dose-dependent sedation, sleep, anesthesia, and coma. It also acts on the reticular activating system. The reticular activating system is the is mainly responsible for the wakefulness of a patient. So when it is inhibited, the patient becomes unconscious. Then sympathetic nervous system is depressed. So this results in hypotension. Whereas the cerebral metabolic oxygen requirement is also reduced, which increases the cerebral vascular resistance, hence thereby reducing the cerebral blood flow and hence reducing the intracranial tension. Hence it is mainly used in the neurosurgeries. It is also used in cerebroprotective mechanism in cardiac surgeries also. This is the mechanism. Then somatosensory evoked potentials, visually evoked potentials, and brainstem evoked potentials, auditory evoked potentials all gets suppressed. And the main important thing is the reverse Steele phenomenon. Steele phenomenon is a paradoxical effect. That is, blood is mainly distributed to the normal areas from the ischemic areas, diverted from the ischemic areas to the normal areas. This is called the Steele phenomenon. Whereas reverse Steele phenomenon means from the normal areas, the blood is diverted to the ischemic areas. So this aspect is mainly used for the cerebroprotective property of the thiopental. So this decreases burst suppression. Burst suppression means increase in the delta waves. Delta waves are responsible for the deep sleep and the anesthesia state. Then in high doses, they undergo desulfuration, acts as pentaborbital. So they are used in CNS depression. Hence finds its place as an anticonvulsant. So in respiratory center, they depress the medullary and the pontine ventilatory centers. They also depress the ventilatory response drive, neurogenic, hypoxic, and hypercapnic drive. Hence, apnea may result. Laryngeal and cough reflexes are always suppressed. Then a great caution to be noticed is the laryngospasm and bronchospasm. This is mainly due to the histamine release from the skin and the muscles of the lung. So hence contraindicated in status asthmaticus. So in cardiovascular system, in normal induction doses 5 mg per kg, BP is reduced. This activates the carotid sinus baroreceptor mechanism, baroreceptor reflex mechanism, which increases the peripheral sympathetic nervous activity, increases myocardial contractility and tachycardia results. Whereas in high doses, they directly depress the myocardium and causes bradycardia. Sympathetic nervous system is depressed and vasomotor system is also depressed, which causes increased peripheral dilatation and blood pooling, which reduces the venous return and cardiac output, hence thereby decreasing the BP. In muscle, this reduces neuromuscular excitability. Kidney, they decrease GFR. This is mainly due to the high protein binding. Now, adrenocortical suppression is also seen, but it is always reversible. Now, liver, it has decreased hepatic blood flow and microsomal enzyme metabolism, hence other drug interactions can result. Placental transfer occurs. Now, induction dose, it is always 3 to 5 mg per kg and maintenance 3 to 5 mg per kg per hour. And anticonvulsant dose, it is about 0.5 to 2 mg per kg can be repeated. In ICT treatment, intracranial tension, it is 1 to 4 mg per kg IV, and ECT, electrocarbot, this is controversial. As an anticonvulsant, this dose produces 0.5 to 2 mg, and in ECT, it is 2 to 3 mg per kg, but without any adjuvants or any preemptive analgesics. Narcoanalysis, that is lie detection. IV bolus 8 mg per kg. Euthanasia, mercy killing, it is used, but now it is not used. Now it's not to practice. Now it is also a cerebroprotective agent, hence finds its place in neurosurgeries. Anti-thyroid activity, so it is mainly preferred in many thyroid surgeries. This prevents the peripheral conversion of T3 to T4, hence used in the thyroid surgeries. Now side effects are allergy, garlic takes. This is mainly attributed to the sulfur component of the drug, and anaphylaxis, but it is not very much prominent unless for the skin and muscles, only skin, otherwise bronchospasm. Then comes porphyria, it is the contraindication, not a side effect actually. Then pain at the injection site. Then this can be avoided by introducing lignocaine prior to the drug. Serious cardiovascular respiratory depression, then laryngeal and bronchospasm. Emergence delirium can occur. Yeah, but it is not profound, so hence can be safely used. Nausea, emesis, and salivation also occurs. Phlebitis, necrosis, gangrene, if injected arterially. Gamma aminolaminic acid is responsible for the porphyria, acute intermittent exacerbation of porphyria. So here is the picture depicting the intraarterial thiopentone injection. This is the injection site, and there is a gangrene of the little finger and the middle finger. This is mainly due to the mixing of the high concentrated 5% or more than 5% solution, concentrated solution with the arterial blood. There will be precipitation of the crystals due to the change in the pH, which blocks the small size arterioles and capillaries, which causes endothelial damage, thrombosis, necrosis, and gangrene finally. So use it with caution. So main contraindications are inadequate airway. In hemodynamically unstable patients, you can use thiopentone in sleep doses. It is not absolutely contraindicated, but relatively contraindicated. Then it can be used as
Hello, Dr. Anu. Hello, Dr. Anu.
Dr. Anu, your audio is unmuted. Please unmute your audio. You are in mute.
Is my audio now?
Yeah. Only now we are clear. Can you go ahead with the slide from the beginning? This one particular slide.
Okay. So, shall I continue with the slide or?
Go for it. Let's start. Yeah. Continue.
Okay. So this is the result of the intra-arterial thiopentone injection, which causes gangrene due to the formation of the thrombosis and the thrombosis of the arterioles and the minimal capillaries. So contraindications as such, it is inadequate airway, hemodynamic instability. In hemodynamically unstable patients, you can use it in sleep doses. It is not absolutely contraindicated. Sleep doses can be used. When catecholamines are completely depleted, you can use this as a mode of induction. Then status asthmaticus patients, it is completely contraindicated for the fear of bronchospasms and the laryngospasms. Porphyria, gamma-amino-levulinic acid synthase, which is responsible for the exacerbation of the porphyrins. Now, hypersensitivity reactions also. Then, what to do if you are injecting it intra-arterially by accidentally? You have to leave the needle at side, heparinize, and you have give lignocaine intra-arterially or papaverine at a dose of 40 mg. And sympathectomy can be done by the stellate ganglion block. Median nerve block can also be done. Then, in pregnancy, for a cesarean section, if you are giving a GA, it could be used as an induction agent. Unconscious mother and a conscious fetus. How can this be possible? This is because of the fast metabolism of the fetal liver of the drug, and also the water content of the fetal brain is high, which really avoids the crossing of the drug into the brain of the fetus. Hence, the fetus is conscious and the mother becomes unconscious. So, propofol. So, other set of slides you can try cracking out. Predecessor of propofol and outdated due to anaphylaxis. Goes in white and comes out green. Antiemetic property of propofol is attributed to the decrease of this element. Okay. Regarding the history, it was synthesis in Imperial Chemical Industries in UK in 1970. Then it was by Kay and Rowley, who synthesized chromophore EL, used it as, but due to anaphylaxis in the egg lecithin present there, they abandoned it. 1989, FDA approved it, and the historical importance is, the famous dancer Michael Jackson, Conrad Murray, who assassinated Michael Jackson, was victimized due to the propofol injection. Now, the structure. This is the isopropyl structure. So, diiso 2,6 diisopropyl phenol. This is the phenol ring. So, these alkyl phenols are oils at room temperature and they are insoluble in aqueous solutions. They are highly lipid soluble. And phosphopropofol is a phosphorylated prodrug of propofol, which is water soluble drug. Now, this is the properties. They are milky white in color, stored at 4 to 25 degrees Celsius. They are isotonic with a pH of 7 to 8.5. Weak acid, that is pK is 11. Degree of ionization. This refers to the degree of ionization. So, this is responsible for the absorption. Then viscous oil in water, not light sensitive, and they are highly lipid soluble and insoluble in aqueous solution. 10 ml, 20 ml, and 50 ml vials and 200 ml bottles were available. Now, propofol, what are the components of propofol? It is a 1%. Sometimes sodium metabisulfite is used as a bacteriostatic agent, but due to the fear of bronchoconstrictions, it is not used nowadays. Instead, 0.005% EDTA is used. Then zoyabine oil is used as an emulsifier, and glycerol adjusts tonicity. Purified egg lecithin is also used as an emulsifier. So this also acts as a GABA receptor, acts on GABA receptors. In low concentration, they facilitate GABA, and at high concentration, they mimic GABA. They act on the beta subunit of the GABA receptors. So this is a central chloride channel. When propofol acts on the beta receptors, chloride channel opens and hyperpolarization effects, and neural transmission is inhibited. Now, the other sites of action of propofol. They inhibit NMDA receptors through sodium channel gating and inhibit acetylcholine release in the hippocampus prefrontal cortex. The sense of well-being is attributed to the increased dopamine concentration in nucleus accumbens after propofol injection, and decreased serotonin levels in the area prostroma through by action on the GABA receptors. This is attributes to the antiemetic effect. So they are also anti-pruritic by inhibiting the medullary dorsal hall transmission and the cyclooxygenase. So pharmacokinetics, molecular weight is 178.27 Daltons, pK 11 weak acid. Volume of distribution is 2 to 10 liters per kg, very high volume of distribution. Clearance 1.5 to 2.2 liters per minute. They also have extra hepatic clearance by lungs and kidneys, 30% by kidneys and 30% by lungs, remaining by hepatic. Then highly protein bound, 95 to 98%. So decreased absorption, decreased filtration. So absorption is through IV route, 1 brainome circulation. That is the time taken for the maximum effect occur after the injection, intravenous injection. They are rapid. Then distributed, very rapid distribution, half-life, that is 1 to 8 minutes. First, it is distributed to the highly perfusive organs like brain, kidney, liver, heart, and rapid awakening occurs after single bolus dose. Then slow distribution occurs to the muscles and then to the adipose tissue. This takes place within 30 to 60 minutes. Then terminally, it gets released after 4 to 24 hours. From the deep compartments, it gets metabolized by the plasma and eliminated. Now, propofol as such is white but gives out green urine, carbolyuria excretion. Metabolized. This is due to the metabolic component quinols. Quinols due to the metabolism of the phenol derivatives and conjugation to the glucuronides, which is responsible for the green color of the urine. So completely opposite to cows. Next. This is the metabolism of propofol. Propofol is first conjugated to the glucuronide, glucuronide conjugates propofol glucuronide, and they become 1,4 and 4-hydroxy propofol glucuronide. This is called as the quinol compound, and this is responsible for the green color urine, carbolyuria. Excretion of phenols in urine, that is carbolyuria. So the onset 1 brainome, that is within 30 seconds, peak 90 to 100 seconds, that is 1.5 minutes. To maintain the intraoperative plane, you need at least 2 to 5 mics per ml in the plasma. So awakening occurs if there is less than half of this amount, less than 1.5 mics per ml. And there is a prompt awakening even after prolonged infusions. This is due to the less contact sensitivity half-life. That is, which is less than 40 minutes. What is contact sensitivity half-time? It is the time taken by the drug to fall by half of its plasma concentration after a prolonged infusion to attain a steady plasma concentration. So, in different groups of people, how propofol acts. Okay. In women, they have a larger volume of distribution and higher clearance rate, but the elimination is half-life is similar for males and females. But in elderly individuals, the dose requirement will be 50% reduced due to the decreased clearance rate and a smaller central compartment volume. Hence, it has to be used in caution with elderly individuals. Then children, they relatively have a larger central compartment and a more rapid clearance rate. Hence, it has to be weight adjusted. Less than 3 years of age, propofol should be given on the basis of weight only. Then, in hepatic diseases, this can be used safely because there is no need for dose adjustment because they have extra hepatic clearance mechanism which compensates for the hepatic disease. So pharmacodynamics, in central nervous system, it causes dose-dependent depression of the cerebral cortex, ascending reticular activating system and medullary centers. It causes sedation, hypnosis, amnesia. So hence called the rightly named as milk of amnesia. Anesthesia, and then respiratory depression. It also reduces the cerebral metabolic oxygen requirement, cerebral blood flow, cerebral perfusion pressure, and hence reduces the ICT. It is also a proconvulsant. But that is explained by greater than 1 mg per kg. If it is given, it decreases the seizure duration. This is due to the metabolite quinol. In autonomic nervous system, they decreases the sympathetic activity rather than inhibiting the parasympathetic activity. Then dose dependent in respiratory system, it causes dose dependent respiratory depression. Apnea occurs in 25 to 30% patients. It also decreases the carotid sinus receptor mechanism, chemoreceptor mechanism, hence by depressing the ventilatory centers, causing hypercapnia and hypoxia. Causes decreased laryngeal and cough reflexes. Bronchodilation. Propofol as such is a bronchodilator, but if it is used with sodium metabisulfate, then it causes that is the main culprit in the bronchoconstriction. It also potentiates hypoxic pulmonary vasoconstriction through potassium ATP mediated vasoconstriction. Now, in cardiovascular system, it decreases the BP by 25 to 40%. It decreases all systolic, diastolic, and also mean arterial pressure. It is a direct myocardial depressant effect and also a vasodilatory effect. So it decreases the cardiac output or cardiac index by 10 to 30% and reduces the sympathetic drive and reduces systemic vascular resistance by 15 to 25%. In thiopentone, you have seen that baroreceptor reflex mechanism activates, but propofol as such inhibits the baroreceptor response. Hence, there is no tachycardia. It only causes bradycardia. They suppress the atrial tachycardias. They have minimal effect on the sinoatrial node and the AV node. It also attenuates heart rate response to atropine. So, in liver, it decreases blood flow. In kidney, causes renal vasoconstriction, decreases renal blood flow and glomerular filtration rate. This decreased glomerular filtration rate is mainly due to the high protein binding of the drug and also carboluria, excretion of phenols in urine. In neuromuscular junction, there will be minimal muscle relaxation, but still it provides a favorable atmosphere for intubation. In eye, it has reduced intraocular pressure. Now, the uses of propofol. And, in pregnant uterus, they have no effect on the pregnant uterus. The uterine muscle tone is not altered, and the fetal mother equilibrium attains within 2 to 3 minutes. Hence, it is required to deliver the baby within 3 minutes. Now, uses, coming to the uses, it is used as an induction agent, maintenance, sedation, antiemetic, antipruritic, antioxidant, TIVA, and NORA. They can also be anticonvulsant, but sometimes due to the metabolites, they can be a proconvulsant too. Hence, not used as a protocol in in convulsions. Induction of general anesthesia. The dose is usually 1 to 2.5 milligram per kg. Dose reduces with increasing age. For maintenance, you need to give 50 to 150 mics per kg per minute, combined with nitrous oxide or opioids. In sedation, you can give 25 to 75 mics per kg per minute IV. It also has an antiemetic action, so you can give it at a rate of 10 to 20 mg IV and can repeat every 5 to 10 minutes or start infusion of 10 mics per kg per minute. Propofol also finds its use in target control infusion to maintain a blood plasma concentration of 1 to 5 mics per ml. So side effects are pain on injection. So you have to give lignocaine or before injecting propofol. Then phlebitis can be there. Anaphylaxis may be mainly due to the components of not due to directly due to propofol, but due to the egg lecithin and the soybean oil to maintain the lipid emulsifying actions. Bacterial growth is possible, but they are made bacteriostatic by EDTA and sodium metabisulfate. Myoclonus, convulsions, and hallucinations due to the metabolites present. They can also result in pancreatitis. Tolerance and abuse can also be seen, and hence it has to be used with caution. Now, propofol related infusion syndrome. When does it occur? It occurs if you give propofol at a rate greater than 4 mg for 48 hours in a rate of 4 mg per kg per hour. So it is highly seen in sepsis patients, cerebral injury patients, traumatic brain injury, and poor oxygen delivery patients. What is the mechanism? They causes uncoupling of the oxidative phosphorylation, hence they causes muscle necrosis, rhabdomyolysis, renal failure, and hyperkalemia, the hallmark. Rhabdomyolysis is the hallmark of Priss syndrome, renal failure, and hyperkalemia. Then impact beta oxidation of fatty acids. So high plasma of free fatty acids, which causes lipemia. Already propofol has lipid emulsion, which causes increased free fatty acid level in the blood. So free fatty acids and in critically ill patients, there will be necrosis of fat and catecholamine-induced lipolysis, which itself increases the free fatty acid level. These free fatty acid levels and the acyl-carnitine complexes is a pro-arrhythmogenic. That is, they causes cardiovascular arrhythmias, dysfunction, and collapse. So what is the treatment? You have to stop propofol. Vasopressors and inotropes can be used. Cardiac pacing in case of any heart block. Then hemodialysis in renal failure, and also ECMO. Now coming to ketamine. So other set of slides. I think you can crack it. It will be more easy, I think. So regarding the history, in 1962, it was devised by Calvin L. Stevens at Park Davis Laboratories, but was introduced on humans in 1965 by Codson and Dominus. So ketamine finds its place in Vietnam War. No, we don't know about the exact history, but just used during Vietnam War. Now, the structure of ketamine. This is an aryl cyclohexylamine pencyclidine derivative. So it has two structures, racemic isomers. They are R- and S+ enantiomers, where S+ is more potent than the other one. So the preservative used will be benzethonium fluoride. They have long shelf half-life, available as 10 mg per ml, 50 mg per ml, and 100 mg per ml vial. Then they have acidic pH 3.5 to 4.5, highly lipid soluble and also water soluble. They are stored at room temperature 15 to 30 degrees Celsius. They are light and heat sensitive, hence should not be stored outside. Now coming to mechanism of action, hallmark mechanism is NMDA receptor antagonist. This is by synaptic plasticity mediated learning and memory is inhibited. So what are NMDA receptors? They are glutamate-gated cations. This is responsible for the increased calcium permeability mediated glycine and glutamate. Glutamate are neuroexcitators. So excess calcium influx may lead to excitotoxicity. Ketamine acts on this and then prevents they antagonize this receptor. This is the structure of the NMDA receptor. So this is the calcium. It has a calcium influx channels. When ketamine gets attached to the NMDA receptors, the neurotransmission the excitability doesn't occur and excitotoxicity is reduced. This is the mechanism by which ketamine acts on NMDA receptors. So ketamine finds its place in antidepressant effect also. This is by this mechanism. When ketamine is not present, the NMDA receptors gets attached to the glutamate receptors, releasing the glutamate, preventing the release of glutamate from the vesicles. But whereas when ketamine gets attached, they don't bind to the receptors, so there will be surge in glutamate, which increases the synapse formation and strengthening. This attributes to the antidepressant effect. So other receptors of action, opioid, they are agonist at kappa receptor but antagonist at mu receptors. Antinociceptive because they inhibit the descending inhibitory pain pathway. Muscarinic antagonist, that is, they cause emergence delirium, bronchodilation, and sympathomimetic effects like atopic. Next, it is sodium channels and L-gated calcium channels inhibitory. That is mainly this causes the local anesthetic property also. Ketamine has a local anesthetic property also. Hence, used as an adjuvant in epidural or caudal. Sometimes in spinal also it finds its place. This is mainly due to this mechanism. They inhibit nicotinic and cytokine receptors, hence analgesia. They also inhibit catecholamine reuptake in the presynaptic and postsynaptic nerve endings. Now, pharmacokinetics. The molecular weight is 238 kilodaltons, pKa 7.7, and it forms white crystalline salt. So it is given either by intravenous, intramuscular, intranasal, oral, or rectal route. Oral route has very less bioavailability due to the first pass metabolism by liver. Intravenous 100% bioavailability is guaranteed, and they are 12%. Their protein binding is very limited, and free drug is more available. Then volume of distribution 2.5 to 3.5 liters per kg. This is 5 times that of a thiopentone. So absorption is through IV. Onset of action occurs within 60 seconds, that is within 1 minute, and the peak affects by 1 minute. If it is through IV route, if it is through IM route, it attains its peak by 5 minutes. Distribution, it is distributed to highly perfuse organs like brain first. Then they are high lipid solubility attributes to the transfer across the blood-brain barrier. They increase the cerebral blood flow. They have a vasodilator effect. Hence, they cannot be used in cases of ICT. This causes increased drug delivery to the brain. Then it is transferred to the low perfuse areas. This is responsible for the psychodynamic effects after emergence. Now, metabolism is through hepatic microsomal enzymes, N-demethylation to norketamine. This is mainly responsible for the hallucinogenic nystagmus and the emergence delirium attributed to ketamine. Then hydroxylation, hydroxyketamine. Then conjugation to inactive glucuronides and water-soluble compounds, and this is excreted in urine. Then excretion is mainly through kidneys, and they are excreted in kidneys, 4% in urine and 5% in feces. Now, this is the metabolism. Acts upon the microsomal enzymes, norketamine. Then they are hydroxylated. Then dehydroxy norketamine. The routes of injection, intravenous, intramuscular. For recreational use, they are used as oral and nasal. Recreational dosage is high because of the reduced bioavailability. So onset of effect within seconds, and intramuscular means it is within 1 to 5 minutes. Pharmacodynamics. So they causes dose-related unconsciousness and analgesia. They are antinociceptive, that is analgesic at the spinal cord level through NMDA receptor antagonism and inhibition of acetylcholine release. This wide dynamic range neurons in dorsal horns are mainly responsible for their inhibition antinociceptive actions. Then they produce amnesia, but they are not profound. Dissociative anesthesia, another hallmark feature of the ketamine. Cataleptic state. Dissociative anesthesia means pain is felt as some other pleasant sensation. Cataleptic state. This is also seen in ketamine. Eyes will be open, reflexes will be preserved, but these reflexes do not protect. That is the main reason for emergence delirium. In emergence delirium after ketamine infusion, nystagmus and lacrimation is increased. Nystagmus is lateral movements, vertical and horizontal movements of the eyes. Then increases cerebral metabolic oxygen requirement and cerebral blood flow. It is a cerebral vasodilator, so it increases the ICT. So always it is used with thiode to blunt the CBF, cerebral blood flow. Cerebral ischemia is protected by NMDA antagonism. It increases somatosensory evoke potentials. Auditory evoke potentials and visually evoke potentials are suppressed. They accentuate the hypercapnic drive. Seizure threshold, no alteration in the seizure threshold. Functional disorganization is no anatomical changes in the brain, but there will be some involuntary movements or excitatory symptoms. This is called as the functional disorganization, which is mainly seen in after post-ketamine anesthesia. Prevents central sensitization and long-lasting enhancement in pain sensitivity after opioids. So emergence delirium, very unwanted feature of ketamine. The psychedelic reactions usually occur after 1 hour after emergence. It includes dreaming, excitement, euphoria, hallucinations, confusions. This is mainly due to the depression of the auditory and the visual evoke potentials. That is mainly on the inferior colliculus and the medial genital nucleus. Now, respiratory system. They have a minimal effect on respiratory drive. Apnea can be seen at large doses. As such, they are bronchodilators, but increase in secretions attributes to bronchospasm and laryngospasm. So use it with caution. Always combine it with anticholinergics. It also antagonizes spasms due to carbapenem and histamine. It increases salivation. Airway reflexes are intact, but they are not protective. So in cardiovascular system, they stimulate the sympathetic nervous system, thereby increases heart rate, cardiac output, and blood pressure. It can be combined with benzodiazepines and inhalation to blunt these effects. So in TIVA, we use ketamine with propofol. So combined action causes the sympathetic nerve stimulation and depression. So in TIVA, ketofol is used. Direct cardiodepressant, they have negative inotropic effect. And this increased heart rate is due to the systemic release of catecholamines, vagal inhibition of norepinephrine reuptake at the peripheral nerve and myocardium. So if in shock patients, this cannot be used. That is, in case of compensated shock, you can use because catecholamines will be present in the stream, and ketamine can increase the reuptake of the peripheral nerve and the myocardium. Whereas in uncompensated shock, the catecholamines will be depleted. So if we use ketamine, produces direct cardiac depressant effect and causes bradycardia or even arrest. It restricts the tissue perfusion and causes increased lactate, hence causes vasoconstriction. They are also arrhythmogenic if used with adrenaline. Now, regarding the coagulation system, it inhibits platelet aggregation through inhibition of cytosolic free calcium concentration and production of inositol 1,4,5 triphosphate. So it is used as an antidepressant. And also it reverses opioid tolerance. It is used in restless leg syndrome. It is used as a preemptive and preventive analgesia. Gargle in post-intubatory sore throat. And induction. The indications are hypovolemic patients in shock, that is compensatory shock, and reactive airway disease, and also in right to left shunts. There will be no effect on shunt fractionation. Maintenance of anesthesia can also be done using ketamine, but limited studies are there. Then TIVA, NORA is non-operating room anesthesia. Then multimodal analgesia, neuropathic pain, chronic pain syndrome, fibromyalgia, phantom pain, migraine, somatic pain. They are also used as an adjuvant in epidural and caudal, but intrathecal use is restricted because of its neurotoxicity due to the preservative. Preservative-free solutions are available and can be used nowadays. They are using intrathecally also. Post-op sedation and pain relief. Sedation with benzodiazepines in ICU. So ketofol. How do we use ketofol? It should be used in a combination of 1:1 ratio. So 0.75 milligrams per kg of each drug should be given, and the recovery occurs after 15 minutes. These because of the rapid elimination of the drug. Metabolism of the drug. Then induction of the general anesthesia. The dose is 0.5 to 2 milligram per kg IV, and if it is given as IM route, 4 to 6 milligram per kg. Maintenance 0.5 to 1 milligram per kg per minute, or 15 to 45 mites per kg per minute IV with nitrous oxide. Then sedation and analgesia 0.2 to 0.8 milligram per kg IV over 2 to 3 minutes, and IM means is 2 to 4 milligrams per kg, half the dose of induction. Then preemptive or preventive analgesia, it is 0.15 to 0.25 milligrams per kg IV. So contraindications: ketamine high, abuse and tolerance are the main contraindications for ketamine. They show many pathological, physiological, physical, and psychological effects. It causes cardiac problems, dysfunctions, collapse, and psychosis, seizures, and also dissociation. Then neurosurgeries, it is mostly contraindicated due to the increased vasodilatory effect, cerebral vasodilatory effect, because they may raise ICT. But if patients are ventilated without any hypocarbia, then ketamine can be used. Studies are there. Then eye surgeries, they raise IOP, so contraindicated. In ischemic heart disease also it's contraindicated due to the tachycardia cost and hypertension cost. Then vascular aneurysms also, ketamine is avoided. Schizophrenia, since it's the antidepressant, schizophrenic patients should not be given due to the psychedelic reactions and the emergence delirium. Ketamine is contraindicated in schizophrenic patients. Preservative is used, neurotoxic, so better to avoid intrathecally. Recreational drug abuse is more common with ketamine, hence to be used with caution. So the most unwanted side effect is delirium, which this is the reason why many anesthetists avoid ketamine. But in case of shock, no one can avoid ketamine. So always combine it with the midazolam. Now wait a minute. So try guessing these jumbled words. Try cracking it out. I correct myoclonus. And imidazoles are not only anesthetics, but also they are used as another forms, pharmacological values. Etomidate used in the treatment of this syndrome. Okay, regarding the history, 1964, Johnson Pharmaceuticals at Belgium devised etomidate, but it was into use only after 1972 in Europe and 1983 in USA. In India, it came to use as 2013. It is used as an antifungal. Also, first it was synthesized as an antifungal only. So it is an imidazole derivative. What does imidazole mean? If carbon atom is between two nitrogen atoms, this is the carbon atom between two nitrogen atoms. This is the imidazole ring, and this is pentyl ethyl 1H imidazole 5-carboxylate sulfate. So etomidate, this is the structure. They act on the GABA A receptors. Produces when they act on GABA A receptor, they mimic GABA and they produce sedation and hypnosis. They act on the 11 beta hydroxylase in the production of the conversion of cholesterol into steroids, hence causing the adrenocortical suppression. Whereas carboetomidate does not have this action. 11 beta hydroxylase hence does not cause adrenocortical suppression, hence can be used safely. Now this produces only sedation and hypnosis. Whereas dimethoxyetomidate, they produce adrenocortical suppression but no GABA receptor, hence used in Cushing syndrome. Now they are hydrophobic. Then pH is 7. Then milky white viscous liquid. They are available as 20 milligram vial and 40 milligram vial. 0.2% solution is seen in 35% propylene glycol. This is called as amidate or lipid emulsion dipura. Then mechanism of action, like propofol, like thiopentone, they act through GABA A receptors only. At low concentration, they are GABA facilitating, and at high concentration, they are GABA mimetic. Pharmacokinetics, onset of action is within 1 minute, that is 30 to 60 seconds. Peak effect is seen after 1 minute. Duration 3 to 5 minutes and terminated by redistribution. Protein binding is 76%. And metabolism is mainly through hepatic and plasma esterases. So half-life distribution half-life is 3 minutes. This is responsible for the anesthesia we give after induction. Redistribution half-life is 30 minutes. That is the sedation. A patient remains sedated even after 30 minutes. Then elimination half-life is 3 hours. Drowsiness effects during this period. Pharmacodynamics, CNS. It decreases ICT and also cerebral blood flow and metabolism rate. Cerebral perfusion pressure is but maintained. They also increase the latency and decreases amplitude of auditory evoke potentials. So they are used in speech and memory test. Etomidate is used other than the anesthetic use. They are also used in speech and memory test. This is due to this property. Then etomidate has also been associated with grand mal seizures. So epileptogenic foci. It's better to avoid an epileptogenic foci. Then CVS, no or minimal change in heart rate, blood pressure, and cardiac output. Hemodynamic changes, there is no hemodynamic change in response to pain and no effect on sympathetic tone. Hence used in cardiac surgeries. This is the main property why we prefer etomidate for cardiac patients. Pregnant patients with cardiac disease, etomidate is the most preferred drug of choice. Then alpha-2 receptors, it increases BP. It acts on alpha-2 receptors and increases BP. Hence, after induction and intubation, there may be a slight increase in BP even after etomidate injection. Now, respiratory effects, no or minimal changes in respiratory rate and tidal volume, but there may be a brief period of apnea followed by a hyperventilation period. This may result in increase in PaCO2, but PaO2 doesn't change. Arterial oxygen level doesn't change. Attenuates the vasorelaxant properties of bradykinin and ester. Now, other effects includes there is no histamine release, very rare allergic reactions, and hepatic and renal blood flow is decreased but clinically accepted. Then adrenocortical suppression. This is the very deadly side effect of etomidate. Hence, it is not used regularly. Only in case of indications we are using it. How it is produced and why it is not used. Because for a level of hypnosis, we require at least 200 nanograms per ml of etomidate. But the adrenal cortical suppression occurs even with the dose less than 10 nanogram per ml. So how does adrenal cortical suppression occurs? Because etomidate acts on 11 beta hydroxylase, which is responsible for the conversion of the cortisol into corticosteroids, aldosterones, and cortisols. And this is a major site of action. And also they also inhibit 17 alpha hydroxylase. This is a minor site of action. And hypnosis and adrenocortical suppression. So adrenal cortical suppression occurs within a dose less than 10 to 10 nanograms per ml, but it occurs after hours. So it is not used in ICU as a sedative agent. But in hypnosis, it occurs within minutes, but with a very large dose, 200 nanograms per ml. Large dose and very limited time is hypnosis, and over hours, but very small dose adrenocortical suppression occurs. So it is used as a sedative hypnotic agent. Conscious sedation can be done. Then it is also used in lie reduction, preferred in cardiac patients as an anesthetic. In traumatic brain injury, they are mainly used in rapid sequence intubation. Rapid sequence intubation can be done either with etomidate or ketamine. Ketamine in case of hypotension, and etomidate in case if there is no hypotension. In cardio version, as a medication, because they have minimal effects on the cardiovascular system. In ICU as infusion, but adrenocortical suppression risk has to be ruled out. Then etomidate speech and memory test. This determines the speech lateralization in the patient prior to lobectomy to remove epileptogenic centers in brain. So rapid sequence intubation in traumatic brain injury. It is always followed by succinylcholine. Okay. In sedation, the doses 0.1 milligram per kg up to 3 doses can be repeated. For general anesthesia, it is 0.3 to 0.4 milligrams per kg IV over 30 to 60 seconds. In ICU, as continuous infusion, but with careful monitoring. As a treatment in Cushing syndrome, 0.2 milligrams per kg. Geriatric patients, pregnant patients, and pediatric patients, it has to be given with caution due to the adrenocortical suppression. So contraindications, pregnancy, pediatric, and they are all related contraindications only. In pediatric patients less than 2 years, it should not be absolutely contraindicated. Otherwise, in pregnancy and geriatric patients can be given. Other unstable hemodynamic, unstable patients, it should not be given. Then abnormally low blood pressure, even with treatment, then these people should not be given etomidate. And adrenal hyperfunctioning of the adrenal gland and hypersensitivity of etomidate. These are the main contraindications. Then side effects are side pain. Injection side pain occurs for at least 80% patients. So always combine it with lignocaine. Then skeletal muscle movements called as myoclonus, up to 30% patients. Opsoclonus is uncontrolled eye movements. Then adrenal suppression can be seen. Hiccups can be seen after etomidate induction. Apnea up to 90 seconds. Laryngospasm is not profound, but it may be seen in etomidate induction. Then post-operative nausea, vomiting, snoring, arrhythmias, and also increase in PaCO2 is the main side effects. Myoclonus can be corrected by pre-treating the patient with magnesium or midazolam. Thank you. This ends up the session. So the online induction is over. So hope you can induce by IV line successfully. Thank you. And all the best for the all final years for the exams. Thank you.
Well done, Anu.
Thank you for your presentation, Dr. Anu. I take pleasure in introducing Dr. Shivakumar, who is a professor and head of the Department of Anesthesiology, Subbiah Institute of Medical Sciences, Shivamogga. His areas of interest are total intravenous anesthesia and low flow anesthesia. He has around 21 publications to its name. And he has been an organizing secretary of the ISA Karnataka conference, and he's been an ISA secretary also in ISA Karnataka. And he has won many awards, proficiency awards and other national public awareness award. He's a university gold medalist in MD anesthesia. And of late, he has introduced virtual reality in community training of CPR. We wish him all the best and welcome to our session, sir. This session is going to be on the pharmacology of neuromuscular blocking agents. Welcome, sir. Over to you, sir.
Thank you, Dr. Sarva, for an introduction. I thank Edward Johnson, sir, and Siva Prasad, sir, for inviting me to the online anesthesia forum. So I'll be talking on pharmacology of neuromuscular blocking agents. 1 minute, please. Good morning, all. So today I'll be talking on pharmacology of neuromuscular blocking agents. So we should understand the history of neuromuscular blocking agents before we use them. Initially, these curare were used as aroposan by South American tribals. Later in 1942, Griffith and Johnson suggested D-tuberculin as a safe drug to be used during the surgery. Succinylcholine, for the first time introduced by Teslev and Folds in 1952. 10 years after that, Baird and Reid first administered pancuronium. The vecuronium and atropurium was introduced in late 1980s. And myocurium was introduced in 1990s. And recently, gantacurium was introduced recently in 2020. Coming to a definition, neuromuscular blocking agents are the drugs that act on neuromuscular junction and skeletal muscle fibers to block neuromuscular transmission. It's so simple. So why do we need a neuromuscular blocking agents? One is to facilitate a muscle relaxation during surgery. Not all the surgeries requires a neuromuscular blocking agents. And second, to facilitate a mechanical ventilation. Again, this only in a severe ARDS and those conditions we have to use the neuromuscular blocking agent for the brief period. And third, to facilitate endotracheal intubation. There are a few indications. I am not going to tell all those indications. These are the main indications for use of neuromuscular blocking agents. So first we should understand what is neuromuscular junction. The neuromuscular junction is association between a motor neuron and a muscle cell. The synaptic cleft, the cell membrane, muscle cell membrane and of the neuron and a muscle fiber separated by a narrow space. That's a very narrow space of 20 nanometer. The neurotransmitter which is responsible for a neurotransmission at a neuromuscular junction is acetylcholine. It is synthesized in a cytoplasm at presynaptic nerve endings by a combination of choline and coenzyme A with the help of choline acetyl transferase. It is stored in a vesicles. Each single vesicles contains a quantum of acetylcholine. You can see these vesicles contains a quantum of acetylcholine. This is a synaptic cleft which is around 20 nanometer. So the acetylcholine receptor, each acetylcholine receptor in a neuromuscular junction normally consisting of 5 protein subunits, normally 2 alpha subunits and beta subunit, delta and epsilon subunit. This a mature or a normal acetylcholine receptor contains these combinations. The only 2 identical alpha subunits are capable of binding to acetylcholine molecule. If both alpha subunits are bind, then conformational changes occurs, which opens the ion channel, allowing sodium and calcium to enter inside and potassium to go out. Acetylcholine channel does not open if only one alpha subunit is bound by acetylcholine receptor. So 2 acetylcholine molecule has to bind to the alpha subunits. There is another isoform of acetylcholine receptor which contains GABA subunit instead of epsilon unit, known as a fetal or immature receptor because it's present predominantly in a fetal muscle. It also referred as extrajunctional receptor, but it present extrajunctionally, especially in some conditions, which I will be discussing later part of my presentation. The cations flow through the open acetylcholine receptor channel, that is sodium and channels goes in and potassium comes out, generating an end plate potential. When enough receptors are occupied by the acetylcholine, the end plate potential will be sufficiently strong to depolarize the perijunctional membrane. Usually, it contains 5 million receptors at the neuromuscular junction. The 10% of the acetylcholine receptors are occupied. It produces the enough end plate potential to cause a perijunctional depolarization. So coming to a sodium channel, we should understand something about sodium channels. So sodium channels, there is a transmembrane protein that can be conceptually as a 2 gates. One is voltage gated and another is a time gated. Sodium ions pass only when both the gates are open. Opening of a gate is time dependent and a voltage dependent. Upper gate is a voltage dependent and lower gate is a time dependent. The channel therefore possesses 3 functional states. At the rest, what happens is the upper gate is closed and the lower gate is open. When the threshold voltage potential reaches, lower gate opens and also the upper gate opens, lower gate will be open already. Shortly after upper gate opens, the time dependent lower gate closes and upper gate will be open till the further repolarization. With the opening of sodium channels and the entry of sodium and calcium ions, sodium channel, the entry of sodium, the calcium ions released from sarcoplasmic reticulum. The intracellular calcium allows the contractile proteins actin and myosin to interact, bringing about a motor contraction. So in this video, you can see how the action potential generated. So first, there is action potential. You see this, when the action potential arrives at presynaptic nerve endings, the calcium will enter into the cells. Calcium will enter into the cells, which causes the release of vesicles. So the release of vesicles and acetylcholine into the synaptic club. The acetylcholine bound to the alpha subunit, which causes opening of a voltage gated channel, voltage gated gate of a sodium channel, which causes a entry of sodium and calcium into the cells and potassium outside the cells, which causes end plate repolarization of end plate. Coming to the classification of a neuromuscular blocking agents based on the duration and mechanism, it can be classified as depolarizing and non-depolarizing agents. So depolarizing agents, we have only one drug, which is short-acting drug, that is a succinylcholine. Non-depolarizing drug, we can be classified into short-acting, intermediate-acting, and long-acting. Short-acting drug is a gantencurium, mivacurium. Intermediate-acting, most commonly used drugs are intermediate-acting drugs, tacrocurium, cisatracurium, acronium, and rocuronium. Long-acting drugs are pancuronium, picuronium, and doxycuronium. So coming to a depolarizing neuromuscular blocking agents, only one drug is available, that is succinylcholine or succinylcholine. So succinylcholine is a quaternary ammonium compound, also called as diacetylcholine or succinylcholine. It consists of 2 acetylcholine molecules which are joined together. Only depolarizing muscle relaxants which is available for a clinical practice. So mechanism of action of a depolarizing muscle relaxant. Depolarizing muscle relaxants very closely resembles acetylcholine and readily bind to the acetylcholine receptors, generating a action potential, which leads to a phase 1 block. Normally, it leads to a phase 1 block. in some conditions, when a prolonged infusion or high doses are given, which may also lead to a phase 2 block, which resembles like a non-depolarizing muscle relaxant. So normally what happens, the depolarizing muscle relaxant closely resembles acetylcholine and readily bind to the acetylcholine receptor, generating a muscle action potential. Unlike acetylcholine, however, these drugs are not metabolized by acetylcholinesterase. The acetylcholine is metabolized immediately by acetylcholinesterase, but succinylcholine is metabolized by pseudocholinesterase or a plasmacholinesterase. So their concentration in a synaptic cleft does not fall rapidly, resulting in a prolonged depolarization of muscle end plate. The continued end plate depolarization causes a muscle relaxation. Because the repolarization is very important, otherwise the time gated sodium channel gate will be closed. So that's why there will be a prolonged depolarization. Because opening of perijunctional sodium channel is time limited, sodium channel rapidly inactive with a continuous depolarization. In case of a phase 1 block, perijunctional sodium channels cannot reopen until the end plate repolarizes. The end plate cannot repolarize as long as depolarizing muscle relaxant continues to bind to the acetylcholine receptor. This is called as phase 1 block. This normally we find during the clinical practice. What happens in a phase 2 block, there is a continuous activation of acetylcholine receptor leads to ongoing shift of sodium into cell and potassium outside. Despite this post-junctional potential return to a normal due to increased activity of sodium potassium ATPase pump, which brings the potassium inside the cell. So normally what happens, sodium and calcium goes out and sodium and calcium comes in and potassium goes out. But in case of phase 2 block, after a prolonged blockage, the potassium goes in, which maintains the, which brings back the old potential, end plate potential to the normal, which leads to a phase 2 blockade. What are the characteristics of a phase 1 depolarizing block? There will be a decreased twitch amplitude, absence of fade with the continuous tetanic stimulation or a train of 4, similar decrease in the amplitude of all twitches in a train of 4, with the train of 4 usually more than 0.7. The absence of post-tetanic potentiation, it's antagonized by a non-depolarizing agents, augmented by anticholinesterase. I will tell you how this will be augmented by anticholinesterase. The metabolism and excretion, rapid onset of action within 30 to 60 seconds. Volume of distribution is very low because it confined to the extracellular volume only because of a low lipid solubility. Short duration of action, usually less than 10 minutes. In circulation, rapidly metabolized by a plasmacholinesterase or a pseudocholinesterase into the succinyl monocholine. As the drug level falls in the blood, succinylcholine molecule, which is present in a synaptic cleft, moves to the blood. So there will be a action will, where the depolarization will stop when the drug moves away from the neuromuscular junction. So main responsible for the stoppage of action of succinylcholine is movement of the drug from the synaptic cleft into the plasma. However, in some conditions, the duration of action can be prolonged, or prolonged apnea after succinylcholine can occur due to a following condition. One is a low pseudocholinesterase level. There are so many conditions which decreases the pseudocholinesterase level. Atypical pseudocholinesterase, high doses are a phase 2 block, or hypothermia. So the condition which decreases the pseudocholinesterase levels generally produces a modest increase in the duration of succinylcholine action between 2 to 20 minutes. These common conditions are liver diseases, pregnancy, renal failure, hypoproteinemia, hypothyroidism, and alcoholics. And some drugs will also decrease pseudocholinesterase like the esmolol and most of the organophosphorus agents, anticholinesterase and pancuronium and oral contraceptive pills. This also decreases pseudocholinesterase. Atypical pseudocholinesterase, structure of plasmacholinesterase is determined genetically by autosomal genes. There are two forms, heterozygote and homozygote atypical pseudocholinesterase gene. The heterozygote for a atypical gene is found in 1 in 25 to 30 patients of European origin, with the one normal and one atypical pseudocholinesterase gene, resulting in slightly prolonged block, that is 20 to 30 minutes. In case of homozygous atypical pseudocholinesterase gene, 1 in 3,000 patients have 2 copies of abnormal gene to produce an enzyme of no or little affinity to succinylcholine, will have a prolonged blockade of more than 4 to 6 hours. So how to measure atypical or abnormal pseudocholinesterase? So this is a quantitative method which it can be measured at the laboratory. It can be expressed in units per ml. Or a qualitative method. Qualitatively, it can be measured by Debye number for the atypical gene. So Debye number, this the percentage of inhibition of pseudocholinesterase activity by Debye is termed as Debye number. This is determined in the laboratory quantitatively in a units per ml. Debye is a local anesthetic which inhibits the normal pseudocholinesterase activity by 80%. It inhibits the normal pseudocholinesterase by 80%, but inhibits the atypical enzyme activity only by 20%. But in case of heterozygous, the atypical enzyme, the inhibition will occur between 40 to 60%. So based on this, we can identify whether it is a normal or homozygous or heterozygous based on the amount of inhibition. So how to manage a succinylcholine apnea or prolonged apnea due to a succinylcholine? This condition is not life-threatening, as we are presumed it can be managed easily, but the risk of awareness is considerable, because especially after the end of surgery, when anesthesiologist who may not yet have made the diagnosis is attempting to waken the patient, that time the awareness will increases. Anesthesia must be continued whenever we suspect a succinylcholine apnea until a full recovery from a neuromuscular block is demonstrable. In such a patient, non-specific estrase, that is 10% of metabolism of succinylcholine will happen through the non-specific estrase, will gradually clear the drug from the circulation. So the patient will spontaneously recover after some time if you continue a mechanical ventilation with the sedation. If we need, we can use the fresh source of a cholinesterase by giving a fresh frozen plasma and continue a mechanical ventilation with sedation and monitor a neuromuscular function so that we can identify the early recovery of neuromuscular blockage. The drug interaction and the special consideration, cholinesterase inhibitors markedly prolong a depolarizing phase 1 block by a 2 mechanism. One is inhibition of acetylcholinesterase. I'm audible, right? Hello?
Yes, sir, audible.
Yes, sir, audible.
Okay. Cholinesterase inhibitors markedly prolong depolarization phase 1 block by a 2 mechanism. One is inhibition of acetylcholinesterase. Because inhibition of acetylcholinesterase, there will be higher acetylcholine at a neuromuscular junction and intensifies the depolarization. Second, inhibiting a pseudocholinesterase. So these are the 2 mechanisms by which the cholinesterase inhibitors prolongs the depolarizing phase 1 block. Small dose of non-depolarizing agent antagonize a depolarizing phase 1 block because these drugs occupy acetylcholine receptors, so prevents the depolarizing agent, that is succinylcholine, from occupying it. But in case of phase 2 block, it prolongs the phase 2, non-depolarizing agents prolongs the phase 2 block. Usually dosage and storage, usually the adult dosage of succinylcholine for intubation is 1 to 2 milligram per kg intravenously. Dose as small as 0.5 milligram per kg can be provide a good intubating condition, provided a pre-curarizing or a defesculating dose of non-depolarizing agents are not used. A repeated small bolus of 10 milligrams or infusion of 1 gram in 500 ml or 1 liter of normal saline titrated to effect can be used during a surgical procedure that requires intense muscle relaxation for short duration, such as endoscopy. But make sure that to monitor a neuromuscular function to watch for a phase 2 block And also there will be a chance of bradycardia during these prolonged infusions or repeated bolus doses because of formation of succinyl monocholine, which affects on the SA node. So usually in clinical practice, we avoid more than 2 doses. Make sure that if prolonged muscle relaxation is required, better to use a non-depolarizing muscle relaxants. In a pediatric patients are often require a greater dose than adult, mainly because of the pediatric patients have a extracellular volume is more because it is limited to the extracellular volume. So they require a higher per kg dosage of succinylcholine. Intramuscularly, children's succinylcholine can also be administered intramuscularly at the dose of 4 to 5 milligram per kg doses, but it will not produce a profound muscle relaxations. Usually, we avoid giving intramuscular doses of succinylcholine. It should be stored under refrigeration between 2 to 8 degrees centigrade and should be used within 14 days after removal from the refrigeration. Side effects and clinical consideration. Succinylcholine is still a drug of choice in India for a rapid sequence intubation and for short duration of intense paralysis. Rocuronium has come big way, but because of non-availability of sugammadex, we don't used commonly for rapid sequence intubation. Still, the succinylcholine is theoretically a drug of choice for a rapid sequence intubation. Another succinylcholine is considered relatively contraindicated in certain conditions in a children and adolescents with myopathies. What are the side effects? Cardiovascular side effects. Succinylcholine acts on a cholinergic acetylcholine receptor in addition to those on the neuromuscular junction. It acts on entire parasympathetic nervous system and a parts of sympathetic nervous system, sympathetic ganglions, adrenal medulla, and sweat glands. A stimulation of nicotinic receptor in a parasympathetic and a sympathetic ganglion and a muscarinic receptors in a SCA node produces a complex effects depending on the dosage we use. Low doses produces a negative chronotropic and inotropic effect, and high doses usually increases heart rate and a contractility and elevated circulating catecholamines levels. Children are particularly susceptible for profound bradycardia following administration of succinylcholine. Whenever we use the high dose of succinylcholine or we use for a intubating dose of a succinylcholine, we have to pre-medicate with the anticholinergic agent to prevent a profound bradycardia. Nowadays, very uncommonly we use a succinylcholine for even in a children's. In adult, bradycardia will sometimes occur when the second bolus of succinylcholine is administered approximately 3 to 8 minutes after the first dose. Succinylcholine sensitizes the muscarinic receptor at the SCA node. The arrhythmias, nodal bradycardia, and ventricular ectopic may occur. The onset of paralysis, fasciculation is the onset of paralysis signaled by a visible contraction of motor unit called as a fasciculation. Because if this is a depolarizing muscle relaxant, depolarization causes a fasciculation. This can be prevented by a precurarization with a 10% of ED95 of a non-depolarizing muscle relaxant 3.5 to 4 minutes before administration of succinylcholine. It is different from a priming because we use here a 10% of ED95. In a priming, we use the 10% of intubating dose. Fasciculation are not absorbed in elderly and young children because the muscle mass will be less in them. The hyperkalemia increased serum potassium by 0.5 milliequivalents per liter, which is insignificant in a normal patients, but it can cause a life-threatening hyperkalemia in certain susceptible patients with a burn patients, chronic myopathy or neuropathy patients. We should be very careful when administering succinylcholine in these patients. What are the conditions which increase the susceptibility for hyperkalemia when we administer succinylcholine? There are so many conditions. The important conditions are burns, major burns, polytrauma patients, severe intra-abdominal infections, spinal cord injuries, prolonged immobilization patients, polyneuropathy, myopathies, and a closed head injuries, stroke, Guillain-Barré syndrome. These conditions we should be very careful. So whenever there is a myopathy or a neuropathy or rhabdomyolysis, we should be very careful in these patients because this can increase increase the hyperkalemia when you administer the succinyl choline. So mechanism of succinyl choline induced hyperkalemia, there will be usually after trauma or burn, there will be a denervation. So this denervation leads to an immature isoform of acetylcholine receptor to be expressed inside and outside the neuromuscular junction. So these immature receptors are very sensitive to acetylcholine, resulting in excessive release of potassium. So life-threatening potassium release not reliably prevented by precurization. Remember that we can't prevent the hyperkalemia by precurization. The risk of hyperkalemia usually peaks between 7 to 10 days following an injury. The minimal during the first 2 days of burns or injury. So surgery with the succinyl choline can be performed in a first or second day of surgery with the major injury or a burns, because the formation of immature receptors takes approximately more than 2 days and which peaks at 7 to 10 days. So myalgia, there will be increased myalgia due to fasciculation. It can be prevented by a pre-administration of rocuronium at the dose of 0.06 to 0.1 milligram per kg. If there is a myalgia has happened, it can be treated with a non-steroidal anti-inflammatory drugs, which is common. The myalgia is very common in a young adults with the muscular adults, very uncommon in case of elderly patients. So what about intragastric pressure elevation? Increased intra-abdominal pressure and intragastric pressure is due to a fasciculation. No evidence that risk of gastric reflux or a pulmonary aspiration. Increased IOP due to increased depolarization of extraocular muscles. There will be a transiently increased intraocular pressure, but there is no evidence suggest a worst outcome in an open eye injury. Not always, it's not always prevented by precurization. So IOP cannot be prevented by precurization, but make sure that avoid a succinyl choline whenever there is an open eye injury is present. Masseter muscle rigidity and malignant hyperthermia, there will be a transiently increased masseter muscle tone, which is common because the amount of the acetylcholine receptor which are present in the masseter muscles are much higher compared to the other muscles. So it increases the masseter muscle tone, but markedly increased tone is a premonitory sign of a malignant hyperthermia. Whenever you think that there is an increased muscle tone, so it is a sign of a malignant hyperthermia. Succinyl choline is a potent triggering agent for a malignant hyperthermia in a susceptible patients. Coming to a non-depolarizing muscle relaxants, classification, this can be classified into benzyl isoquinoline groups, steroidal group, and newer one is a chlorofumarates group. Benzyl isoquinoline groups, we know that there are atracurium, cisatracurium, mivacurium, duxacurium, and recently AV002 or CW002 call it. And historically, there are some drugs which are the D-tubercularium, metacurium, calamine, and decamethonium. Coming to a steroidal group, pancuronium, which is commonly used, pipacurium, vecuronium, and rocuronium, and chlorofumarates, gantacurium is a newer drug which is available now, which is ultra short-acting newer drug. So how this non-depolarizing muscle relaxant acts? Non-depolarizing muscle relaxants are competitive antagonist which competes with the acetylcholine for acetylcholine receptor. Non-depolarizing muscle relaxants bind to the acetylcholine receptor but incapable of inducing any conformational changes necessary for the channel opening, just bind to the receptors. So this, because acetylcholine is prevented from binding to its receptor, no end plate potential is develops. So neurovascular blockage occurs even if one alpha unit is blocked. So even one alpha unit of a non-depolarizing muscle relaxant is blocked, which prevents the acetylcholine binding. So it causes a muscle relaxation. What are the characteristics of a non-depolarizing muscle relaxants? There will be a decreased twitch amplitude, the fade with the tetanic stimulation. Tetanic at a train of 4 ratio shows less than 0.7. Post-tetanic potentiation occurs, the absence of fasciculation, and antagonized by the anticholinesterase drugs. Why the potent drugs are slow in onset? The normally what is potent drugs will have a lesser number of molecules. Lesser potent drugs have the more number of molecules. More the number of molecules available at a receptor, more rapid the onset of action. Lesser number of molecules will have a will be available at the receptor to get the response in case of potent drugs. So that's why the more potent the drug is, less the onset will be slower. Pancuronium acts very slow, comparatively less potent like a rocuronium, it acts faster because more molecules will be available to bind at the level of acetylcholine receptor. The priming dose, giving a 10% of intubating dose 5 minutes before the induction will occupy enough receptor, which occupy approximately 75% of the receptor, so that paralysis will quickly follow when the balance relaxant is administered. So to increase the onset of action, we can give a priming dose. The priming dose, we are giving 10% of the intubating dose. Pre-curarizing dose, we are giving a 10% of ED95. So unique pharmacological characteristics is a suitability for intubation. None of the currently available non-depolarizing muscle relaxants equals the muscle relaxation that of succinyl choline. Onset of non-depolarizing relaxant can be quickened by either by using the larger doses or, as I discussed, by giving the priming doses. Twice the dose of ED95 is usually required for the intubation. For neuromuscular blockers, ED95 is the dose that produces 95% twitch depression in a 50% of the individual. Sorry. The potentiation by inhalational anesthetics, volatile anesthetic decreases the non-depolarizing dosage by at least 15%. Actual degree of potentiation depends on the which inhalational agents we are using. Desflurane is more potent in decreasing the non-depolarizing dosage than as compared to sevoflurane. Sevoflurane is more potent in the isoflurane. Isoflurane is more potent in the enflurane. Enflurane is more potent in the halothane and nitrous oxide. And it also depends on the what non-depolarizing muscle relaxant we are. The pancuronium is more affected by the inhalational agent as compared to the other drugs. The histamine release, there are certain drugs which certain neuromuscular blocking agents which increases the histamine release. Pancuronium, atracurium, and mevacurium are capable of releasing histamine. The mast cells can be prevented by slow injection or pre-treatment with the H1 or H2 blockers. A general pharmacological characteristic of non-depolarizing agents, the temperature, hypothermia prolongs the blockade, but two mechanism is decreases the metabolism in case of mevacurium, atracurium, and cisatracurium, and delaying the excretion in case of pancuronium and vacuronium. In case of acid-base imbalances, respiratory acidosis potentiate the blockade of most of the non-depolarizing muscle relaxants, and antagonism is reversal because in case of acid-base respiratory acidosis, there will be a decreased amount of calcium available at a neuromuscular junction, so it potentiates the blockade. Electrolyte abnormalities, hypokalemia and hypocalcemia augment the non-depolarizing blockades. Hypermagnesemia potentiates the non-depolarizing blockades by competing with the calcium at the motor end plate. But you should remember that only hypermagnesemia, when we give a dose equivalent to the when we give for eclampsia or preeclampsia, then only it causes the antagonizes potentiates the non-depolarizing agent. Using a 500 mg or 1 gram of magnesium does not prolong the duration of non-depolarizing agents. Concurrent diseases, most of the neuropathy and myopathy increases the duration of non-depolarizing muscle relaxation as with the depolarizing muscle relaxation. But certain conditions like cirrhotic liver and chronic renal failure increase the volume of distribution and low plasma concentration of a given drug. So greater initial dose but a smaller maintenance dose might be required in these patients. Because of volume of distribution is increased, extracellular volume is increased, we have to give higher initial bolus doses, then followed by lower subsequent doses. And neuromuscular monitoring is mandatory in these cases because identify exact dose is very difficult in this patient. It may lead to a underdosing or most oftenly it is a overdosing and delayed recovery. So drug dependent on a hepatic and renal clearance may demonstrate a prolonged action. Coming to individual non-depolarizing neuromuscular blocking agents, Atracurium is a benzyl isoquinoline structure. It undergo Hoffman elimination. 45% of the drug which undergo atracurium undergo a Hoffman elimination, which is a non-enzymatic elimination, which occurs both in vitro and in vivo. And remaining 55% which undergo stress elimination. Metabolism is independent of hepatic and renal clearance. Onset is 2 to 3 minutes. The intubation dose is 0.5 milligram per kg and infusion dose is 5 to 10 microgram per kg per minute. It must be stored in 2 to 8 degrees centigrade. It loses its potency of 5 to 10% at every month when it kept outside in a room temperature. At a room temperature, it should be used within 14 days. There will be a dose-dependent histamine release, significant if the dose is more than 0.5 milligram per kg, which may lead to a bronchospasm. It should be contraindicated in patients with the bronchial asthma or a bronchospasm in a COAD patients. Ladenosine toxicity can occur if the storage is improper, because in case of Hoffman elimination, ladenosine is produced if kept in a room temperature, which is a tertiary amine, is breakdown product of atracurium by Hoffman elimination, which causes CNS excitation and precipitates a seizure. The ladenosine is metabolized by a liver and eliminated through a renal system. The cis-atracurium is a stereoisomer of atracurium, which is 4 to 5 times more potent than atracurium. It's metabolized only by Hoffman elimination, but it does not produce a histamine, and 5 times less production of ladenosine than atracurium. Intubation dose is 0.1 to 0.15 milligram per kg. Onset is almost similar, 2 to 3 minutes. Infusion 1 to 2 microgram per kg per minute. It must be stored in 2 to 8 degrees centigrade. At room temperature, it can be used up to 21 days. Coming to pancuronium, it's a steroidal non-depolarizing muscle relaxant. The metabolized by deacetylated by liver. It metabolized products have some neuromuscular blocking properties. Excretion primarily by a renal by 40%, although some lesser extent by a bile, that is 10%. Elimination can be delayed in a renal and liver dysfunction. Require initial larger volume in case of liver disease due to increased volume of distribution. It's common with all the non-depolarizing muscle relaxants. It's stable at a room temperature. Some of the adverse events, with respect to pancuronium, the hypertension and tachycardia because of vagal blockade, sympathetic stimulation, catecholamine release and decrease uptake of catecholamines. The arrhythmias can occur, ventricular arrhythmia due to increased AV conduction and catecholamine release. Combination of halothane, tricyclic antidepressants and pancuronium is arrhythmiogenic. The allergic reaction due to a bromide, because of its pancuronium bromide, most of the allergic reaction is due to a bromide. The most commonly used steroidal non-depolarizing is a vacronium. The similar potency like a pancuronium, metabolism lesser extent by a liver, primarily excretion by a biliary and 25% by a renal. Long-term infusion in ICU causes a polyneuropathy due to accumulation of 3-hydroxy metabolite. The risk factor for a polyneuropathy with respect to vacronium is female gender, use of steroid, sepsis, long-term use, and renal failure. Dose 0.08 to 0.12 milligram per kg, infusion around 2 microgram per kg per minute. The women are 30% more sensitive due to increase in fat mass. Coming to rocuronium, it is 6 to 8 times less potent than vacronium. The rapid onset of action, Okay. Coming to a acronym, most commonly used steroidal non-depolarizing neuromuscular blocking agents, similar potential like a pancreonium, metabolism lesser extent by a liver, primarily excretion by a biliary and 25% by a renal. Long-term infusion in ICU causes a polyneuropathy and accumulation due to accumulation of 3-hydroxy metabolite. Already discussed these things. Coming to a rocuronium, 6 to 8 times less potent than a vecuronium. A rapid onset of action, 90 seconds, because lesser potent the drug, more molecules available to bind at the acetylcholine receptors. No metabolism occurs, primary excretion by a biliary and lesser extent to the renal. Prolonged action in a liver disease and a pregnancy. Elderly, duration of prolonged due to the decreased hepatic blood flow. No active metabolite, better choice for prolonged ICU infusion. Dose is 0.45 to 0.9 milligram per kg. Infusion is 5 to 10 microgram per kg per minute. The intramuscularly 1 milligram per kg in case of infants, or in case of children, 2 milligram per kg can be given. Intubation should be done 5 to 6 minutes after intramuscular dosage. Drug of choice for a pre-curization and rapid sequence induction wherever the sugammadex is available. Coming to a gantacurium is a newer class of non-depolarizing neuromuscular blocking agents. It belongs to a chloroephemerates. It's provided in lyophilized form. It's unstable in aqueous solution. It is ultra short acting duration of action. Undergo a non-enzymatic degradation by two mechanism: cysteine adduction and ester hydrolysis. Dosage is 0.2 milligram per kg. Onset of action is 1 to 2 minutes. Duration of action is 5 to 10 minutes. Recovery can be accelerated by hydrophonium or exogenous administration of cysteine. The histamine release observed if dose is more than 3 times the ED95 dosage. Coming to another newer drug, AV002 or CW002. It is a newer investigational drugs, non-depolarizing agent. It is a benzyl isoquinoline fumarate ester-based compound. Intermediate duration of action. Undergo a non-enzymatic degradation by a two mechanism similar to the gantacurium, cysteine adduction and ester hydrolysis. So these are my references have used for the preparation of this slide. Thank you.
Thank you, sir. Thank you for your wonderful presentation. I thank both the speakers for their presentation. Over to Shiv Prasad to close the session. There are no questions in the chat box also.
Are there any questions? Thank you very much, sir. It was a very enlightening presentation. If there are any chat questions, we'll directly ask you, sir. We can answer.
Okay, sir.
So we come to the end of this session. Thank you, postgraduates. And I wish all the postgraduates who are having exams a very best of luck to you. Thank you all. We can end the meeting.
Thank you, sir. Thank you.
Thank you. Thank you. Thank you very much.
Shilpa, we can end the meeting.
Okay, thank you, Pa. Thank you.
Thank you, sir. Thank you, ma'am.
Thank you. Thank you.